So let's talk about drug distribution and ask ourselves what happens after the drug enters the circulation. So in this segment, we're going to focus on distribution, which tissues see the drug first, why some drugs disappear into fat or protein, and why that matters for onset and duration. So let's apply the idea of absorption and bioavailability to a realistic athlete-provider interaction. So here the athlete says, my provider gave me propranolol to take for test anxiety. I have a hard time swallowing pills, so is it okay if I crush it up and put it in some jelly? And the question sounds practical, but pharmacologically it matters a lot. The athletic trainer's response here is no. Propranolol has an enteric coating designed for maximal absorption in the small intestine. Its bioavailability is low, so crushing it may lead to very little systemic absorption. See, the athletic trainer's response here is understanding that some medications are designed to release a drug in a certain way or at a specific rate. And if we crush them, we may change the intended absorption pattern. In fact, we might even reduce the effectiveness or increase the risk of side effects. So the answer is not automatically yes, but rather whether a pill can be crushed depends on why that dosage form exists. Some pills are designed to protect the drug from the stomach, and some protect the stomach from the drug. And some are designed to release over time. So before changing the dosage form, we have to know whether that change would alter where and how the drug is absorbed. And this is where we connect back to chemistry and the route of administration. And we might use a usable rule where ionized drugs cross membranes poorly, non-ionized drugs more easily. And if we understand that weak acids like aspirin may be absorbed more readily in acidic environments like the stomach or in this case the small intestine, other drugs may favor different regions of the gastrointestinal tract depending on their chemistry. So the point here is not to memorize every pKa value or pH related impact on absorption, but the point is to recognize that drug formulation, the drug's chemistry, the environment of absorption, these all interact. So when a patient asks whether they can crush a medication, this isn't just a question of convenience, but it's actually a pharmacologic and a pharmacokinetic question. Because crushing the medication may change where it dissolves, how quickly it's absorbed, and how much of the drug ultimately reaches the systemic circulation. So our key takeaway here is formulation and route of administration can strongly affect absorption and bioavailability. So patients should not crush, split, or alter a medication unless the provider or pharmacist confirms that it's safe for that specific formulation. Let's take a look at drug distribution. See, drug distribution asks a simple but important question. Once the drug is in the bloodstream, where does it go? Different tissues are going to receive different amounts of blood flow, and different tissues also vary in their ability to take up or store a drug. Highly perfused tissues like the brain, liver, kidneys, they may see the drug earlier, while low perfusion tissues may receive it more slowly. So a drug's effect is shaped not just by the dose, but also where the drug is distributed after it enters the circulation. So we're asking the question, how does the drug get to where it needs to go? We often see a distribution of the drug kind of partitioning into different areas of the body, and that's what we see on the figure, right? From the blood plasma, making it into the skeletal muscle, the fat, extracellular fluid. See, if a drug needs to get from the blood into the tissues, we likely see the tissues with high blood flow getting more of the drug. Alternatively, tissues that are very large, like the skin, oral antibiotic used for cellulitis, large tissue blood flow goes to the skin, and so we're going to get a lot of distribution of that medication to that area. So, giving ibuprofen, you want that drug to get into the muscle, right? If we're talking about treating for a muscle strain or some type of soreness. If we're talking about tissues with high blood flow, those will tend to receive a lot of the drug in a short period of time, while areas of fat and bone, those are going to receive less drug and it takes longer. Therefore, a low dose is satisfactory for muscle strain given the size of the tissue, while a physician may prescribe higher amounts of the dose if it needs to get into, let's say, the bone. So when we check the efficacy of a drug, we may need to check the blood to determine how much of the drug has made its way into the blood. So dosing might require a patient to come back over time to get their labs checked to make sure that the dosage is correct, that they're getting the amount that's necessary for that treatment. Alternatively, if we look at cartilage as an example, cartilage has a low blood supply, and given the poor perfusion, more drug may be needed and maybe needed to provide, assuming the therapeutic index allows for an increase in the dose without getting close to that lethal dose. So we see blood flow to the tissues, tissues with high blood flow, organs with low perfusion, the size of the organ, very large organs like skeletal muscle, and then concentration. All of those elements are critical when we're looking at the ultimate pharmacologic effect. So blood flow is one of the biggest determinants of early distribution, and high flow organs receive drugs sooner. Low flow tissues, they're going to receive it later. Even muscle, which can receive plenty of drug in total because there's so much of it. So it doesn't always behave like the highest perfusing organ, especially at rest, but it may be receiving plenty because of the size of that tissue. Now, fat and cartilage have relatively low blood flow as well. And this means the tissue perfusion helps to explain why some effects happen quickly and others are delayed. And you'll note that on this figure, we see blood flow to the muscle is low, although there's a lot of it. The muscle might be getting plenty of the drug, whereas fat and cartilage that have low blood flow in comparison to the muscle don't receive as much. Volume of distribution, this helps us think about whether the drug mainly stays in the blood or spreads widely into tissues. So here's an example. A high volume of distribution suggests that much of the drug has left the plasma and entered the tissues. A low volume of distribution suggests it stays more confined into the circulation. Okay, that matters because a drug with high volume of distribution, meaning it's leaving the plasma, it may actually take longer to show its full effect in some cases. And it may also behave differently with changes in body composition or tissue binding, because more of that drug is leaving the blood, making its way into the tissues, saturating the tissues prior to making its way into the blood where it's now showing an effect. Take hydrocortisone as an example. Hydrocortisone is fatty, hydrophobic drug, which means more gets into the fat before it gets into the blood. So it may take a little bit longer for that drug to show its effect. So how long does it take for the drug to have an effect? Well, this is where you have to understand the volume of distribution. Based on the equation where we're looking at the total amount of the drug in the body divided by the drug that's actually in the blood plasma, if we said a drug with high volume of distribution, this would have a propensity to leave the plasma, enter the extravascular compartments of the body, meaning that a higher dose of a drug is required to achieve a given plasma concentration. So we'll say that again, but conversely, a drug with a low volume of distribution has a propensity to remain in the plasma, meaning a lower dose of the drug is required to achieve a given plasma concentration. Let's make a volume of distribution practical. So a patient starts Prozac and wants to know why it's not helping after 2 weeks, or whether a double dose would make it work faster. And this is exactly the kind of question that should make us think about distribution and time course. A drug with a high volume of distribution leaves the plasma and partitions into the tissues, and the clinical response may not be immediate. Doubling the dose is not the right answer. Understanding distribution helps explain why a patient and correct dosing matter. So the patient asks, my provider gave me Prozac for depression 2 weeks ago, but it doesn't seem to be helping. Should I take a double dose? So the athletic trainer or the provider is responding, no, Prozac has a large volume of distribution. So it may take some time for that drug to saturate the tissues prior to being seen more in the blood plasma where it actually may be introducing its effect. So in this case, it can take a month before some of the effects are noticeable. Again, a drug with a high volume of distribution has a propensity to leave the plasma and enter the extravascular compartments, meaning a higher dose of the drug is required to achieve a given plasma concentration, or it may take longer for that dose to saturate the tissues in order to give that intended response. But again, the physician has designed the dosing strategy around what's good for the athlete. Again, if we're nearing a lethal dose by doubling or tripling the amount, that's of course not the right answer. We may need to give a smaller dose over a longer period of time until the tissues are saturated. Now, protein binding, this adds another layer of complexity to our conversation. If in the case of a drug being highly protein bound, a lot of that drug may remain attached to the proteins, like albumin. And that's going to be rather than circulating into its free active form. In other words, that can lower the immediate availability and can also create interaction problems, especially if a second drug displaces the first one from its binded state. So with highly protein-bound drugs, plasma concentration, tissue delivery, and drug competition, these all become clinically relevant factors to keep in mind. See, if a drug is highly protein bound, then it binds to the protein a lot. So you may need, or the physician may need, to give more of the drug to saturate the protein before the drug becomes available as freely unbound circulating throughout the body. So our question in purple here is, what happens if another agent competes for the same protein binding site? So highly protein bound drugs given simultaneously will mean that the drug with the greater affinity to latch on may not allow the other drug to bind because it's saturating all the protein. Therefore, the drug that has lesser affinity may actually circulate more in the blood and have a greater impact, in some cases leading to side effects, because now there's far more that was intended to be in the blood because it's not protein bound due to the competition. So in this matter, binding site competition must be considered for polypharmacy, that is multiple drug prescriptions for a patient. As an example, let's say a patient's taking the seizure drug Dilantin, phenytoin, and then goes to a counseling office, right? And the provider at the counseling office prescribes a low dose beta blocker. So now the person is given propranolol, and in this case, more of the Dilantin comes off of the protein because those are competing for those binding sites. It has a greater effect in the body, and therefore that additional Dilantin in the body makes the person more drowsy. So this is why it may be critically important to ask if a patient has been prescribed new medications. If they're taking multiple medications, that may be the cause of new symptoms, especially if they're seeing different providers. So in our scenario, provider A, physician, prescribed one medication, provider B, from the counseling side, prescribed a different medication. So as we're navigating signs and symptoms, asking those questions about last oral intake, but also medications that we're taking, because there may be competition for some of these binding sites.